So this was a poster that the real world team from Johnson & Johnson, from Jensen, definitely helped with. And I'm very happy to have been able to guide them. And I learned a lot from this analysis as well. Basically, as I've alluded to, the way that we dose talquetamab in the future will look absolutely nothing like how we've dosed it so far. Because we've seen that, for example, even if you look at Dr. Chari's data from ASH 2023 with a prospective cohort of Monumental-1, where they either kept patients at exactly the same dose level of 0.4 mg per kg weekly or 0.8 mg per kg every 2 weeks, or dropped it in some way, either the dose or the dose frequency, and they found that toxicities improved. And there was, I would argue, a non-significant improvement actually in duration of response, probably because people are able to stay on drug for longer. And so we tried to look at real-world usage of talquetamab. It's hard because it's literally only been approved in the US and Europe for barely, a year, maybe more than a year at this point. And so we looked at patients from the initial approval, which was, I think, in August 2023 through March 2024 was our cutoff, the latest we could do. So this is hot off the press. These data will continue to evolve naturally with time. And basically, we found that there were some patients, I think about maybe 20% of patients actually technically a third of patients had not received prior commercial BCMA therapy. Some of them may have gotten BCMA therapy on trials, to be fair. But as I alluded to earlier, there are some patients who are getting GPRC5D bispecifics before BCMA therapies of any type. And again, that's allowed, and that actually may have some advantages, as we've talked about earlier, and as I talked about in my separate debate. So I think that was one takeaway. And the other takeaway was that we looked at actually the time to less frequent dosing. The data are too immature for us to actually look at PFS with any type of an approach, but we looked at how often are people de-escalating lower than every 2 weeks if they start on every 2-week dosing, or lower than every week if they start on weekly dosing. And big picture, about a third of patients do de-escalate their dosing over time, typically around 4 to 6 months or so. We saw in our study of the patients who had, any type of talquetamab and got through the step-up dosing, about half of them, at least in this cohort, were being maintained. Actually, it was mostly more like 16% of them were still on weekly dosing. About half of them were on Q2 week dosing, but we did find significant numbers of patients who were on Q3 week dosing, Q4 week dosing, or even less frequent. So actually about a quarter of patients were on at least every 3 week, every 4 week, every 8 week, or even every 12 week dosing. Again, that is not evidence-based prospectively, and I wouldn't routinely encourage that. However, I do think at least Q2 week is that sweet spot. One, as we alluded to, fewer toxicities. 2, probably longer duration of response, less T cell exhaustion that might work well for patients. You actually might see better efficacy. And 3, obviously less time toxicity coming into clinic. So for my patients, I typically start them on the Q2 week dosing from the beginning. And as soon as they've achieved a good level of response or having any sort of toxicities, I move to every 4 week dosing. And that's my sweet spot. Labs every 4 weeks, and then talquetamab dose every 4 weeks.